And our third objective is to inspire policy and funding commitments to strengthen WASH in healthcare facilities and scale up, and clear calls to action for policymakers and development partners and implementers. And to set the scene, I will invite Anna Mzinga, our country director from WaterAid Tanzania, to come and give award. Thank you, Dadan.
Jamhuri ya Muungano wa Tanzania. A warm welcome everyone into this session, and I'm invited for a keynote speaking while looking forward to really interact and learn from everyone who has been invited. Karibuni sana. Distinguished guests, colleagues, esteemed partners, allow me to begin by describing a very simple picture. A young woman, expectant and hopefully, walk into a health facility in a rural or even urban Tanzania to deliver her child. She is anxious but determined. She trusted that here, in the hands of skilled health workers, she and her baby will be safe. But imagine her shock when she discovers that there is no running water in the maternity ward and access to decent toilet is questionable. Imagine the midwife unable to wash her hands between deliveries. Imagine a newborn entering the world where sanitation is poor and infection lacks in the very place meant to offer protection. This may not be an imagination for too many families in our country. It is a reality, and it is a reality we can and must change together. Our recent review of WASH integration into RMNCAH paints a complex picture, some encouraging progress, yet persistent and urgent challenges that demand action. On women of reproductive age between 15 to 49 years, WASH integration is moderate. Antenatal care services often include health education about safe water, hygiene, and sanitation. According to the 2022 Service Provision Assessment, 41% of facilities providing antenatal care had hand washing stations with soap and water, suggestion a baseline for hygiene support, Ministry of Health DHS Program 2022. So you can note the gap between 100% and 41%. The National Family Planning Guidelines mention hygiene, but lack operational indicators to assess WASH integration at facility level, resulting in implementation gaps. This is from Ministry of Health 2020. On the pregnancy and childbirth, WASH integration is relatively stronger in this area, though national coverage remains moderate. Clean birth practices, including hand hygiene and safe delivery environments, are promoted particularly in health sectors, supported mostly by development partners. The WASH Fit Assessment Report from 2022 indicated that 52% of health centers and hospitals met WHO standards for safe delivery environment. However, service quality is often donor dependent, and major challenges remain in water availability, sanitation, and waste management across many regions. Some regions, such as Kigoma and Shinyanga, have reported notable improvements due to the targeted maternal health projects yet national consistency is lacking. On the postnatal and newborn care, exhibit weak WASH integration. Hygiene promotion is usually limited to post-delivery health talks and follow-up on household level WASH practices is very minimal. The limited reach of community health workers in reinforcing hygiene messages further hampers these efforts. Poor sanitation and hygiene at the house level continue to contribute to neonatal infections. According to the 2023 Ministry of Health postnatal evaluations, only 25% of mothers received a postnatal visit within 48 hours of delivery, which severely limits the opportunity to reinforce hygiene and newborn care practices. On the infants and young children between 0 and 59 months, WASH integration is moderate and often linked to nutrition programming. Hygiene behavior such as hand washing and food safety are promoted through interventions like baby-friendly community interventions and routine growth monitoring sessions. The integrated management of childhood illness packages also include WASH elements, though cross-sectional coordination remain weak. Follow-up on hygiene messages at the household level behavior uptake. According to the Joint Monitoring Program report, only 61% of rural households in Tanzania had access to basic drinking water as of 2023, affecting the sustainability of WASH practices taught in clinics, and this can be also reviewed through different studies by UNICEF and WHO and JMP 2023. Adolescents and youth between 10 and 19 years, WASH integration is weak. While National School Health Program highlight the importance of WASH, particularly around menstrual hygiene management, implementation remain inconsistent. Many schools lack safe, private, and unusable sanitation facilities, which undermines girls' ability to manage menstruation and access sexual and reproductive health services. The 2023 National Adolescent Health Scorecard found that only 35% of secondary schools had separate MHM-friendly toilets for girls, underscoring a gap between policy and practice. Moreover, adolescent-friendly health services often lack structured WASH components, and there has been a limited investment in infrastructure or provider training specific to adolescent needs. But we might ask a relevant question: why integration matters? We often speak of safe motherhood, of child survival, of adolescent health, but let us be honest, none of these goals can be achieved without WASH. A mother cannot deliver safely if her midwife cannot wash her hand. A newborn cannot thrive if the facility lacks clean water or safe waste management. An adolescent girl cannot manage her menstrual hygiene with dignity if she lacks safe toilets. Therefore, without WASH, the promise of RMNCAH will remain unfulfilled. The good news is that this is not beyond our reach. It costs just about $1 per person per year to ensure WASH in every healthcare facility in Tanzania by 2030. Think about that. The price of a bottle of water and a loaf of bread, that is all it takes to safeguard the health of every mother and every child. Few investments in health are as cost effective. For every shilling invested in WASH, we save multiples in reduced infection, fewer hospitalization, stronger child growth, and resilient families. This is not only affordable, but also achievable. And if we have the will, what are the best practices can we draw from this reality? As I close, I am eager to learn more about different unities and also from the ministry, especially PORAC, SRWSS program, and experience from Pwapa district, particularly from Water for People, as well as insights from maternal health initiatives led by AMREF. I know that each of you here today can speak firsthand from your own experiences. Colleagues, friends, partners, behind all of this are human lives. The choice before us is simple. Do we continue with the fragmented approaches, leaving mothers and children exposed to preventable risks? Or do we seize this opportunity to integrate WASH into every part of RMNCAH to make safe motherhood, health, childhood, and dignified adolescent a reality for every Tanzanian? The cost is small, the returns are immeasurable, and the moral obligation is undeniable. Together, let's make this vision a reality. Thank you very much.
Thank you very much, Dada Anna. A big round of applause to Country Director. And now I would like to invite Mr. Seleman Nyondu from PRALT to give us a brief of the government perspective before sharing a documentary on the SRWS program highlight. Karibu, Mr. Seleman.
Okay, thank you very much. Good morning, everyone. So, my name is Seleman Nyondu. I'm working as Head of Environmental Health and Sanitation at PRALT. I wanted to introduce a little bit about the program, the Sustainable Rural Water Supply and Sanitation Program, which is the government program, the implementation since 2019 and ends up in this 2025-26 this financial year. So this is the program actually which is implemented by Ministry of Water as well as Ministry of Health, PRALT, as well as Education. And it has two result areas. Result number one is the water supply, which is done by rural water supply and the sanitation. And result area number two, it is on sanitation hygiene, which is mainly implemented by PRALT while provided oversight in terms of policy and the guideline from Ministry of Health. So this program we have remarkable achievement in the areas of intervention to ensuring that access to wash services in primary health. When I say primary healthcare facilities, I refer to dispensaries, health center, and district hospitals. And in this, we are ensuring access to water, sanitation, and as well as healthcare waste management. So in this documentary, we try to provide a snapshot on what have we done in terms of washing healthcare facilities, addressing child health. So please welcome to look in this short documentary. Then you will see the impact the program have made in this area. Thank you.
Katika mradi huo ulioanza kutekelezwa mwaka 2020 ukitarajiwa kufikia tamati mwaka 2026, serikali inajenga miundombinu ya maji, vyoo vya kisasa vya watumishi na wagonjwa wa nje yani OPD, vyoo vya walemavu, vichomea taka vya kisasa na kidijitali, matenki ya kuhifadhia na kusambazia maji, vinawia mikono vya jamii na inakarabati na kupanua vyumba vya kujifungulia. Maeneo mengi ya pembezoni mwa miji na hasa yaliyoko mipakani, mradi wa WASH ulizingatia hilo, na zahanati ya Umurisimbi ikawa miongoni mwa vituo vya kutolea huduma vilivyonufaika na uwepo wa mradi huo. Elimu haina mwisho. Hofu ya kumpoteza mtoto nayo inaongeza umakini. Darasa ni kuhusu usafi, wanafunzi ni wanakijiji, mkufunzi akitumia uzoefu kuwanoa kisawasawa. Hii ndio zahanati mpya ya Buzirasoga hapa Sengerema inayowafanya wenyeji kutembea kifua mbele. Kupitia mradi wa WASH, karibia kila kitu kimejengwa upya, na hili ndilo jengo la zamani lililokuwa likitumika kutolea huduma za afya kwa wananchi.
Na hasa ujio wa haya majengo yanatupa imani kama sisi wananzengo ambao tayari tuna familia kupeleka wake zetu wanapokuwa ujauzito kujifungulia pale. Kwa hiyo mama ameupiga mwingi, tunashukuru sana.
Sasa kila kituo cha kutolea huduma za afya ya msingi kikijengewa miundombinu rafiki, kuanzia mifumo ya maji, vyoo na vichomea taka vya kisasa na kidijitali, ili kuhakikisha usalama wa watoa huduma na wanaohudumiwa. Ndiyo, na serikali imelifanya hilo ili kuhakikisha watu wake wanaendelea kuwa salama kiafya.
Tangu kuanza kwa mradi wa huduma endelevu za maji na usafi wa mazingira vijijini, halmashauri ya wilaya Geita tumepokea kiasi cha fedha bilioni 2 na milioni 47 na laki 999. Vituo ambavyo vimeboresha huduma za maji na usafi wa mazingira ni jumla ya vituo 38 katika vituo 59 vya serikali, ambayo ni 64%.
Tunaporejea Biharamulo, Rahel Doto ameruhusiwa kurejea nyumbani baada ya kujifungua salama. Yeye ni shuhuda mwingine kuihubiria jamii kuwa kujifungulia katika kituo cha afya au zahanati sio mateso wala fedheha tena.
Huduma ziko vizuri, unapokelewa vizuri, unahudumiwa vizuri, na maji ya kutumia kutosha, hakuna mapungufu yoyote.
Asante TAMISEMI, kwa hili mmevikwa taji la ushindi kwa kulinda utu na kujali maisha ya watu.
Utoaji wa huduma ya afya bila malipo.
Thank you so much. And now we'd like to hear and see another best practice from WASH in child health. And this is lesson learned from Mpwapwa. And this will be presented from a representative from Water for People. Karibu sana.
Can you hear me? Can you confirm that you can be able to hear me? Okay, so my name is Rosie Riwa. I'm the program manager working with Water for People Tanzania, and we would like to also showcase our experience in child health in relation to the WASH, water, sanitation, and hygiene. And we are going to present the intervention, we call it Baby WASH. And the program that I'm going to present or to showcase is called Baby WASH for Better Beginning, Advancing Child Health in Mpwapwa District Council. So Baby WASH was the model that we use in Mpwapwa, at least to link WASH in healthcare facility, but also WASH in the child health and child well-being. And what did we do that? Through our annual monitoring, we just identified that sometimes the parents or caregivers has direct impact to the child health and well-being. So among from the education that we are providing in our healthcare facilities, this included WASH, healthcare education provided to the healthcare to the caregivers and parents who are RMNCAH clinics. So, we piloted it in 20 villages, and this was coming from this data. Before we started, we had like 17,000 of the rare cases among under 5 children, and we noted that this was contributed to the practices of the parents and the caregivers. You may scroll up. So based on this, we designed a model, and we developed the technical materials together with the technical people, health officers, people from RMNCAH clinics, to at least to educate mothers who attend RMNCAH clinics, and also fathers. As we know, also fathers, they are also encouraged to go to RMNCAH clinics. But also we train the CHWs on baby wash models, on training baby wash materials, so that they can do the door-to-door visit, targeting households that have under 5 children or have the pregnant mother. So this is what we did. We trained through the pilot stage because we wanted to see if this model if this model works. So we trained 50 health workers, 30 female and 20 males on baby wash model. And after we trained, they used that model to train women who attend the RMNCAH clinics, and also the father who attends the RMNCAH clinics. And the CHWs uses the printed material to do the door-to-door visit to the household with the pregnant women and children under 5. And the behavior that we promoted is proper hand washings in a critical moment, including before breastfeeding, after changing the baby diapers. But we train also safe disposal of child feces and use the diapers. And we also train on a clean and safe space for the infant, because we know the infant sometimes they are praying grounds, how the best practice the parent and caregivers can help their children to grow in to play in the healthy environment. But hygienic food preparation and utensil use, as we know that if the mother or the caregiver does not have adequate knowledge on food preparation, safety practices on food preparation, it can also be the case that if she has infection, that infection can transfer from the mother or from the caregiver to the child. But also train on active males involvement. As we know, it is the responsibility of all of us to take care of our child. So we train them active male involvement and family support in a baby wash practice, such as father, if you have the child, make sure maybe you don't enter in the house with the shoes, because maybe those growing child can take the, maybe they can contaminate themselves. So we have different aspects when you wash the baby napkin. Maybe you are supposed to throw that water to the toilet instead of just throwing it to the grounds. So it has different packages, messages, goes to the caregivers and the parent. And here we target even house girls and those helper apart from mother and father. But we know the child is normally taken care by different people in the household level. So the result we obtain from that pilot, you may scroll up. Those trained CHWs, they have done outdoors, house-to-house visit to promote different behavior, including now construction of improved toilets and hand washing facility to those in a household. And this is what we get in 2023 when we were done our baseline. We had like 79 households with latrine, but after the door-to-door visit and sensitization with special inclusion to those kind of families, it was raised to 2,929 households. They have been able to construct the latrine. And we have also managed to improve dignity and safety and healthy families in the area that we have piloted, and we have reduced the cases of diarrhea and hygiene by 3,000 because we have been monitoring those cases in the healthcare facility that we have targeted to work. So because of that result, in 2025, we collaborate with Dodoma region now, because this pilot was done in Mpwapwa. So now we wanted to pilot it, to scale it at the regional level. So at the Dodoma region, what we did together with the people from the RASI office, we developed the message, and we, in collaboration with Health Promotion Unit from the Ministry of Health, to accredit and to preview those technical messages. And from that, we targeted to now to use the human-centered messages and the inclusion of people who cannot see, and to create animations, video that can be used in healthcare facility. I think we are all aware some of the healthcare facility have those screens. So when women waiting for the service, they can sit down and see those messages in the screen. But also for the CHW, we procure some smart projector. Smart projector can be used even if they visit the household. So the message now comes from the paper side. We use the audiovisual, animated videos with sign language to include people who with disability, and also with audiovisual clips, posters and charts, radio presenter mentioned. Now we scale it to be included in the radios and social medias, including Facebook, TikTok, and Instagrams and YouTube. So that is what we have been done in Scale Up. So we are planning now to do dissemination through TV screens and in healthcare facilities of state, community radio stations, smart projector for CHWs, but to print media during home visit and group session. So that is what we are planning to do. And in conclusion, we can say from the pilot that we made in Mpwapwa, through use of community health workers and frontline health workers, we see that the baby wash can be integrated in one among the education that women or caregivers or parents can get in LSH clinic, and it can help to reduce the diarrhea cases and other communicable diseases, infection. So if you scroll up, can you help me to scroll up? You will see the QR code to scroll up to the poster. Yeah, you will see the QR code that you can also scan and see other audiovisual contents, animated videos, posters, and everything that we have prepared through this program. And we hope that maybe after we piloted it again in Dodoma region, maybe at the national level, it can be taken to another regions as well. So maybe you can just scan the QR code and you can see a lot of content that has been presented here. Thank you.
Thank you very much. Please, let's give a big round of applause to Rose Riwa. She has presented very nice things that they have been doing in Mpwapwa. And now, to finish, we are going to welcome AMREF. They are going to present maternal health best practice. WASH as a driver of improved outcomes. Well, I hereby welcome, okay, a representative from AMREF. Here is the mic.
Okay, good morning, everyone. Okay, my name is Dr. Serafina Mkua. I work with the AMREF as a program manager for RMNCAH, and I'm here to share with you an experience of a project which we implemented for 4 years in 2016-2020. So this is a completed project, not a pilot anymore. So this project is all about integrated WASH initiative in RMNCAH services. A project which was known as a Canada-Africa initiative to address maternal child mortality. This project was funded by Global Affairs Canada, and we implemented together with Ministry of Health, PRAJ, together with the WaterAid, our partner, and Regional and District Health Management Council. Remember way back in 2016, our country had high maternal mortality, of 556 women dying per 100,000 live births. And among the regions which were contributing to this high maternal mortality were the Lake Zone regions, including Geita region, which had poor health indicators, including maternal mortality rate, but also neonatal mortality. So as AMREF, this prompted us to design and implement this project under the support of GAC, as I said. And we had some baseline indicators that we looked at. And after the 4 years, we again looked at the similar indicators to see whether there was improvement or not. The main indicators included maternal death, neonatal death, antenatal visit, especially for visit and first visit, but also health delivery and home delivery. Since we know that Geita was among the regions which also had scarcity of water, and during the beginning of the project, we did baseline and feasibility to the facilities to see the general situation, where most of the facility did not have water, running water, especially in the maternity ward, labor ward. And again, most of these facilities had an improved toilet, latrines, which were outside the maternity ward. And in the labor ward, there was no toilet, or if there is a toilet, then there was no running water. But also when we looked at the waste management and the disposal, there were no facilities proper for waste management and disposal. So as a result, we looked at all this situation and find that this could be among the causes that are contributing to infection and sepsis, and the poor delivery condition in the health facilities, which could also be contributing to this high maternal mortality and neonatal mortality in those facilities. So what we noted and what we implemented, could you please, could you move the slides, the next slide? Okay, so what did we do? What we did was basically we constructed wash facilities. In those facilities, we identified 12 facilities in Geita, and Geita DC and Nyangwale DC. There were 4 health centers and 8 dispensaries. We constructed placenta, pit, and incinerators in the 4 health centers, but placenta, pit, and ash pit were constructed in all the 12 facilities for safe waste disposal. We also, together with our partner, we constructed boreholes in all facilities, 8 facilities, and we also put rainwater harvest to allow running water, especially supply in the labor ward and in the maternity ward. We also constructed 4 theater to improve the quality of service of maternal and newborn care for CMOC service delivery, but we also refurbished and renovated 8 maternity ward and labor ward to allow to create inclusive environment for childbirth and delivery, as well as postnatal care. We also, apart from implementing in the health facility, we also did some demand creation activities at the community, where we train community health workers who worked hand in hand with the community leaders and the traditional birth attendants, who actually were supporting women to deliver at home. And by then we train them so that they escort women and refer them to health facility for delivery. We also supported community health workers to ensure that they promote, they create awareness and promote the community to attend antenatal care and deliver at the facility instead of delivering at the health, at a home or to the traditional birth attendant. So again, can you move back to the first slide? I would like to show you some of the results, changes from the baseline to the end line. Can you kindly move up the slide? The first slide, sorry. Yes, so if you look at the results, you will see that most of the home delivery reduced from 46% to 16% towards the end of the project. And if you look at the deliveries at the facility, at the dispensary, the deliveries increased from 16% at baseline to 33%. And at the health center, where CMOC service were established, deliveries again increased from 23% to 37%. To 41%. And looking at the antenatal care visit, where most of the women at the beginning of the project were not attending the 4 antenatal visit, adolescent women increased from 51 to 73%, while adult women increased their 4 antenatal visits from 43% to 63%. Next. So here you can see these are some of the constructed theater and the maternity ward at the facility. These are the incinerators and the WaterAid tank, which were constructed to receive water from the borehole that was dug in the health facility. If you look at the maternal mortality ratio, in both Geita and Nyang'hwale, the rates were very high, 149 and 170, but up to the year 2022, when we had the last TDH, the recent TDH, you would see that Geita has reduced to 29 maternal mortality ratio, and in Nyang'hwale there are no any deaths which are reported. So to conclude, I would say that collaboration along the sectors is very important and very critical to tackle maternal mortality, but integrating WASH initiative into the health service delivery, into the RMNCAH services, is very critical to improve maternal indicators, and especially the health of a woman and also a child. Again, I would like to insist on the partnership, strong partnership that we have, really helped in terms of sustainability of the project, but also the intervention which are continuing to be implemented in Geita, and also issues of accountability, where we also implemented community scorecard, and the community is able to account the services that is delivered at the facility. Community health workers and the local government structures, they play essential role in reaching remote and underserved communities. So that is all about our experience in Geita in terms of integrated RMNCAH and WASH initiative. Thank you for listening.
Thank you very much, Dr. Sarafina. And thank you very much to all the representatives who shared the best practice. It is very clear from the initial presentations that WASH is not just infrastructure, it is preventive healthcare. Integrating WASH into RMNCAH is one of the most cost-effective ways to reduce maternal and child mortality. And now, to continue this discussion, we are going to have a panel dialogue and reflections, and I'm going to invite my co-moderator, Ms. Christina Mhando, to continue.
Thank you very much, Rebecca. My name is Christina Mhando. I'm Head of Policy and Advocacy for WaterAid Tanzania. I would like to take this opportunity, after hearing all the best practices, lessons, success, and beautiful stories from people that we work with on the ground, how RMNCAH has helped them to improve in terms of health outcomes. Let's talk now. So I would like to take this opportunity to invite my panelists. I will call one by one. I'll start with Anna Tenga-Mzinga. Anna Tenga-Mzinga is a country director, and she has over 20 years of experience in strategic planning and finance, with 15 years in leadership roles. She has been championing inclusive wash services at WaterAid. She led the launch of WaterAid Tanzania 5-year strategy 2023-2028, focusing on securing funding, enhancing government collaboration and relationships, forming partnerships to ensure sustainable wash access for all in Tanzania. Welcome. Selemani Yond. He is a head of environmental health and sanitation at the President Office, Regional Administration and Local Government. He has over 10 years of experience in public health and WASH. He coordinates the Sustainable Rural Water Supply and Sanitation Program, which we also initially. He leads World Bank supported WASH initiative in Tanzania in enhancing rural health and sanitation efforts. Welcome, Selemani. Dr. Happiness Wilbrod. She's a visionary leader with 12 years of experience in leadership, strategic planning, and program development. She believes in transformative power of communities for sustainable change, with expertise in technical oversight and service delivery in health and WASH sectors. Dr. Happiness aims to advance a reformed, evidence-based approach to ensure sustainable access to WASH services. Her commitment focuses on improving health and well-being for communities in Tanzania and beyond, supported by her foundation in medicine and public health. She is a country director for Water for People. Welcome. Dr. Serafina Baptiste Mkua is a strategic public health specialist with over 15 years of experience in public health leadership and project management. She is a program manager for women and youth at AMREF Health Africa in Tanzania, focusing on RMNCAH and nutrition, passionate about women, children, and adolescent health. She has led impactful initiatives and fundraising efforts. Previously, she was a national program coordinator for Sexual Reproductive Health Rights Alliance and clinical researcher at Muhimbili University, among other roles. Welcome. Thank you. So this is the time we will get to hear from our panelists, but also we will have an opportunity to hear from you. We will give a chance to for questions or suggestions or comments about the entire session, but we will start with our panelists here. I'll start with Country Director WaterAid Tanzania. I loved it when I heard that just one loaf and one bottle of water, a cost of less than $1 can help to ensure that there is WASH in healthcare facilities per person per year. Why is integrating WASH into urban policy and budgets non-negotiable? And what are your top recommendations for government and partners? Tell us.
Yeah, thank you very much, Christina, for a very good question. And I will be just re-emphasizing, since we started this morning, all discussion has been around that. But I also loved a lot the last presentation from AMREF on how it has shown remarkable outcome from the collaboration and from the project that we did from WaterAid and AMREF, supported by Global Fair Canada, and that was focusing into integrating WASH into RMNCAH. The results speak by itself. And as I also provided some narrative around the costing of WASH in health, especially in RMNCAH, only a bottle of water can actually ensure we have access to WASH in healthcare facilities. So the first rationale that I would say is around affordability. if we could look at it in terms of $1 can actually ensure full access of wash in healthcare facilities, then we'll look on where that $1 is coming from. Where do we have to drop a bread? Where do we have to drop a bottle of water so that we can ensure 100% wash in RMNCAH, but in healthcare facilities where a lot of communities are getting access at. The second issue that I really like, and it resonates so well with myself, my background really in finance, is really on the multiplier effect that it has into the economy, into the well-being, but also in the overall health of the community. Imagine investing $1 and be able to have a multiplier effect of $8.6 in health and economic benefits. This has been actually researched, and you can see that you will get a lot of gain by cutting costs that will go into the total treatment, but also into preventing the time that will be spent when the family has to deal with the infection in the family. But in the other hand is looking at the evidences that show that investment into wash in health actually reduce remarkably the odds of maternal mortality. And we have seen some studies from different countries like Bangladesh, India, and Nepal that has seen that a simple action like hand washing has really been able to prevent child from dying, from the reduction of 49% in maternal mortality. But also we have seen that this is an area where indicated clean birth practices are among 19 life-saving interventions that could actually reduce global maternal deaths by 28%. Probably the recommendation. I have two recommendations, Christina, if you'd allow me. Yes, and yes. The first one is really to the government, and particularly to the Minister of Health. If we could work together with partners to gather the data. I really like the theme that we have of harnessing data utilization and technology to accelerate universal health coverage. How can we work with partners to gather data, and especially looking at the budget and planning by also using the evidence from different baseline wash assessment to allow development of costed roadmap that will allow targeted investment on specific period of time to cover the existing gap in this area. But secondly, this is really a key request for me, but rather than a recommendation from the Minister of Health through different departments to look at how they can work together with us, but it is essential to explicitly integrate WASH to the RMNCAH. And I'm looking at the strategy that are coming, upcoming 1+4. How can we engage WASH experts and also practitioners to ensure that WASH aspect and integration is actually included into this strategy? Thank you very much.
Thank you very much. I hope we are doing these recommendations. My team is noting down because we will speak about it as key takeaways at the end. Now I'll move to Poraj. From the government perspective, what has been most important lessons from the data use to inform implementation of WASH integration into RMNCAH through programs like Sustainable Rural Water Supply, which you mentioned. But also, I want to also, after that, to tell us delivery of WASH service is one thing, and also sustainability is another thing. We all have wash facility at our homes. There's time, taps are broken, and they need replacement. Can you also talk about sustainability? Yeah, welcome.
Okay, thank you very much for these questions which you have provided. First of all, I have to start actually the issue of access to WASH in healthcare facilities is something which is very crucial. And actually what we have learned from the data is that always we have this data we are producing within the same sector for access in terms of WASH as well as the data around maternal and the child health. But are we using those data to utilize those data so as we can improve those services? For example, currently, WHO estimate about 26% of the death, maternal death, which are happening, are linked directly to infection within our healthcare facilities. And we understand that when you have poor wash in our healthcare facilities, then the risk becomes very high for infection, morbidity, as well as mortality. So are we linking these two things and see on how we can integrate in our healthcare facilities so that we can ensure the outcome of provision of these maternal and child health services are becoming better? Currently, for example, in the country, only 52% of the primary healthcare facilities have access to reliable water supply. Means that in only this 42% of the healthcare facilities is you can find water the time which you need water. But in most cases, the water is limited. So they need to address also this area very clearly. And through the program of sustainable rural water supply, which among areas which the program is addressing, is accelerating access to WASH services within the healthcare facilities. And within the period of 4 years, we have done a lot in primary healthcare facilities where the burden is. One of the issues we are doing in terms of maternal, in dispensaries, when you go to those rooms of dispensaries, delivery rooms, you find it's just a bare room. There is no wash services there. Water are not connected within there. Toilets are found a little bit far from those buildings. That affects dignity. And someone may think going to deliver in the dispensary, something becomes very difficult for people to decide. And decide maybe to deliver at home. Why? Because it's where she thinks there is a privacy. Because when I'm coming from delivery, then you are escorting me some meters away to the toilet. That's very difficult. So program decided to do some extension in the rehabilitation to provide toilet and the wash facilities within those. So by doing that, there have been remarkable increase in facility delivery for those facilities. Because as we have seen in that video, women now are very confident because they are getting privacy. When they enter in the delivery rooms, they ensure that the washroom is there, water is there. So when they come out, actually they are going to home after being discharged. So that one is what is very important in terms of issue of delivery. Now, another issue which we have touched is the issue of sustainability. We have made very good infrastructures over there. So the sustainability depends. It can be categorized, maybe I can categorize myself in two. One is in terms of using those facilities. They need like paying water bills and whatever. And another part, it is in terms of preventive maintenance. Do you allocate funds for preventive maintenance? So that is an area, actually, we have already started. In the government, actually, we have already prioritized within those facility comprehensive health plans. There is a priority area for environmental health, sanitation, and hygiene, which is there, which they are supposed to allocate there. But having only the priority area does not assure you that fund will be allocated there. It needs the mindset changes of the facility management to prioritize WASH, that this is important and it's critical for provision of health, of our essential healthcare services. Now referring, maybe last one, back to this theme of the universal healthy coverage. Actually, I said that it's very difficult in 2030 to achieve universal health coverage without ensuring universal WASH services to our healthcare facilities. Thank you.
Thank you so much. Thank you so much, Selemani. Actually, you reminded me, like us mothers, imagine during labor time when we even forget where our slippers are and the toilet is far away from the main building. How does that feel? Oh, okay. So let's see about child health from Water for People. Your initiatives link the WASH directly to child health outcomes. What specific lessons that you would like to tell us, especially on scaling up across other districts? And how can data help target such interventions more effectively? And also, addition, are those materials available for all of us here to access and use it when needed? Yeah, thank you.
Okay, thank you very much, moderator Tina. And maybe I'd like to thank WaterAid for this panel. I think if you look at the composition of the sessions for the Tanzania Health Summit, you realize issues around WASH are less discussed. And yet we are all healthcare workers, we are all people from the health sector, but maybe we dwell more into curative than prevention. And even when we speak about prevention, we speak less of water, sanitation, and hygiene. So I believe in the coming years we will see more and more WASH forums, and that is what I'm trying to draw to, integration that Anna had spoke about when she started to address. So Anna and Yondu have spoken about the healthcare facilities, but we know after the delivery, after this child are born, then we have this critical time when you have to take care of the newborn at home. The first 28 days, which are very critical, and then 5 years, which are also very critical, when we see a lot of morbidities and a lot of mortalities to the children. But also, it is that time when the child development is critical. So if WASH is not enhanced, if a simple thing like washing hands, like how one has spoken, is not enhanced, and these children are getting frequent illnesses, it will lead to stunting. And what does it mean by stunting? It will lead to low IQ. It is the generation that we are developing of people who cannot think and a very low economic value in the long run. So for real, the implication of one bottle of water and a loaf of bread is a long-term impact in 20 years, 30 years to come for the generation we are making. So that is why we looked at WASH and baby WASH, and the uptake from baby WASH, we took it from the Water Sector Development Plan, is one of the key deliverables that was to be attained. Making sure that we enhance, we have modules, people are told, and people are aware. People know that they need to take care of the babies, but they don't know how to take care of the babies in a right way. And taking care of a baby doesn't mean just that child, but it is again replicate to the whole family. So what we did is being done also, I believe, by other partners, but maybe we have pieces here and there being done in fragmentation. It is high time that we look into everything that we are having and jointly see how now we take care of this child from the day of birth, 48 hours after discharge, to the first 28 critical days and to 5 years, and make sure that we prevent them from frequent diarrhea. Like in Mpwapwa, it was among the top 10, but ranking the second among the top 10 diseases for under 5s. And I think it is like that in most of the rural areas where you find water is scarce. And also, again, it is the same even for adults. So it will be like a transmission within families, and then when they go to the healthcare facilities, if the healthcare facilities are not well equipped and they don't have WASH facilities, it is even worse. So maybe in less than a year, when we did that intervention in those villages, by just stressing on the messaging, right way of messaging, but also customization, because language is spoken differently, taboos and behaviors are different in different communities. We saw a decrease of more than 3,000 cases in less than a year, and we've just begun, but we believe maybe coming next year we shall be able to showcase how the data is changing and how the mobilities and mortalities are also decreasing in the district. And now we are working with the region, Dodoma, together with the health promotion. So that is one, but the second one, maybe when I go to the lessons, I can say again is stressing on the power of integration and looking at a person in totality. Let our approaches be human-centered. We look at a person not in pieces. This is not a mother who will deliver with no water at home, or a mother who will deliver with no sanitation facilities at home and at the healthcare facilities. So in our programming, let us think of how about when they go back home, do they have these facilities? We have seen in the data, just by the community health workers going door to door, in 1 year the number changes from 800 toilets to over 2,000. And that is not input that we have injected money, no? It is the community understanding and using their own money, own funds and their own efforts. So most of the time we will say we don't have funding, but the communities we are serving are capable of initiating and improving their services if we approach them in a right way. Yeah. So it is how we customize our messages to make sure that it is reflecting the need and the taboos of the communities. The second one is blending the healthcare workers and the community messaging. So when they go to the healthcare facility, they find the right message, and when they go to the community, they find the similar message in the language, and they are able to interpret and take those changes. We have learned also that really when we speak about water, sanitation and hygiene, it is not smooth, because in these areas where we are going, we have seen a project from a program that TAMISEMI is doing. You may go with all the messages, but the village has no water. So what does that mean? Again, sitting as a Ministry of Health and speaking, the Ministry of Water is sitting in another end. I think we may need also at some point to have them participate and see and learn and strategize on how we link health and water, which are very critical and maybe inseparable. But also, I think another thing we have learned is consistency. Behavioral change is a process. It doesn't happen overnight. So when this messaging is taken to the communities, I saw a presentation from Anna saying when the hygiene behavioral change, the uptake, if there is no consistency, the uptake is very low. So our model engages staying at the communities and continuing to engage them most of the time, and with consistency, they start changing. So thank you, Tina. The materials that we have that have been developed from Papua and for Dodoma region, but we are working with the ministry to see how we can have those streamlined. But they are available. If you scan the QR code, you'll be able to at least see what have been developed for now. We have ensured inclusivity. People who cannot hear, they can see, and sign languages have been integrated. So again, I'd like to appreciate and call for integration and joint effort in making sure that we reach everyone.
Thank you very much, Dr. Happiness. Thank you so much. Let's hear now from ARMREV. We saw clear evidence from baseline and end line of improvement. What's innovations that made biggest difference for maternal health? And what can other stakeholders learn from you?
Okay, thank you so much, Tina. I also would like to thank my colleague who have narrated very well the importance of having the two services well integrated at the health facility, especially in labor wards and maternity ward, but also at the facility in general. So coming to your question, as I presented earlier, I think we have had different imagination, and I would like also you guys to imagine you are escorting your auntie or your cousin sister who is in labor pain to the facility, and then just to find that the facility does not have water, and you are turned to be told that go to bring water from the well or surface water, spring water around the facility, far away from the facility. And then when you bring that water to the facility, just to find that the woman in labor is not able, wants to go to the toilet, but the toilet does not have water, or there's no adequate toilet facility in the labor ward. But at the same time, there's no water, no soap for hand hygiene after coming from the toilet, and all those complexities found at the facility. And when I'm talking about this story, it's not a story really, it is a reality which we found in Geita in most of the health facilities, as I mentioned earlier in my presentation. So what we did as AMREF innovatively is to integrate the WASH facilities, WASH initiative into the RMNCAH service delivery point. As I mentioned, we were able to first of all, to renovate the labor wards to ensure that there is running water in the labor wards, in the delivery where the child is being born, but also at the postnatal care, there's enough water, and also there's toilets also accompanied, like our colleague from the government. Currently they are improving the facilities, and we know that all over the country most of the facilities are being improved, which is pretty good, but we can do more around that, because as Dr. Happy mentioned, still in the facility WASH is not given that high priority. As much as WASH is contributing a lot to sepsis and infection transmission, so with the WASH facility in the service delivery area, we ensure that there's adequate infection prevention and control practice implemented in the facility. So improving the standard of quality of maternal newborn child care in the facility, especially around childbirth and during postnatal care, these are very critical in saving the lives of number of maternal and child lives which has been saved, but also preventing unnecessary death. Not only that, but also this also it is critical for respectful care and also dignified care for women and children in the facilities. It is also connected with the social and the emotional support to these women. So to conclude, I would say that most of the facility, or in all the facilities, it is important and it must have infrastructure that are necessary for meeting the health and the needs of the women and children, and particularly WASH integration in RMNCAH services. But also areas where labor, childbirth, and postnatal care is taking place, it is important to make sure that these areas are very hygienic, they are very well organized and comfortable to maintain continuity of care, and that way will ensure that there is achievement of universal health coverage. So the last thing I would like also to add is my colleague from the government has already mentioned, but mentioning is easier, but practicing it might be a challenge. Ensuring that there is adequate allocation of funds, not only putting a budget code in the comprehensive council plan, but ensuring that the money is there and the facilities are improved, and the money is used really to improve WASH facilities in the facility, so as to improve and to enhance the health of women and children. Thank you.
Thank you very much. Thank you very much. Naomba makofi to my panelists. Okay, we have heard everyone here was talking about how WASH is a core enabler of quality RMNCAH services, and most of us are appreciating that it remains overlooked. Is it something that you have the same perspective? I would like to invite 2 questions for the first round because of the time, and then I'll come back just in case the time allows us to continue. So, okay, I want 2 hands first, and then start from already, and there. So we start from here. Yes, please welcome.
Thank you so much. The discussion is of vital help. I'm very much pleased with the job the PRAG is doing and Seleman Yondu. The challenge to do with sustainability when we talk about WASH is financing. What have been done, and we were aware before, the problem was financing. We are doing CHP. We have the budget code. The ceilings not allow you to have a water borehole. It's not allow you to buy a sim tank of 10,000 liters. For example, think of the dispensary found in Egarura in Sengerema district, where the ceiling in Papo kwa Papo, NHIF, ICHF is 7 million maximum. You need to be buying drugs. You need to pay for electricity bills. You need to motivate staffs. And again, basket fund is around 1.5 to 2 million. How do you do that? The time is yet. We need to design on the financing mode. There is no way we will get out of this. The shout you are making is to do with NHIF, the exemption of pregnant mothers, under 5 vaccine. Let us talk about this. Dr. has talked it very clearly in a bolded word that WASH has been talked about less comparing to other agendas in this summit. This should be of priority. Everyone here and outside, let us take this on board, financing mode. That is the key in making this business sustainable. The second thing, we have something to do with the equity and inclusion.
Okay.
There are some of the facilities they have no access, and sometimes on table they have been less discussed how to make it possible to access water. This to be taken on board and discussed. Data have been there, but the quality of discussions, the magnitude that will make it out, has not been addressing the same thing. Third, okay. I'm almost
Is
done.
that the third question?
Excuse me, that will be the last.
Okay.
We are doing something to do with community engagement, talking much more of community behavior change. Not all the communities have been taking this into their considerations to make it of priority. Would we add something to do with law enforcement? I'm very much happy to be the part of this. Thank you.
Thank you very much for the good questions. I hope we are, yes? Oh, sorry, we forgot to give the guidance. Before sharing your reflection, please introduce yourself. So give back the mic.
Excuse me. My name is Dr. Darson Andrew. I'm a district medical officer of Sengerema, which is in Mwanza.
Okay. Thank you.
Yes, thank you. I'm Richard Sambaika from the University of Dar es Salaam. I'm quite excited to be part of this panel. I'm in the forum. My question is around the intersection between WASH and climate change when it comes to the availability of water in the first place. I'm just wondering whether the panelists can reflect on how can we bring at the center of the discussion, whether it's policy or programming, the agenda of climate change, to ensure that water is going to be available at home, whether we are talking about at the facility level. Availability has to do with the changes that we are also seeing and experiencing globally. And I'm raising this with very much passion because we have seen in other programs that farmers, for example, in their everyday life, there are seasons where they struggle to access water just for basic utility. And I'm just wondering, how does it happen, or what are the consequences when it comes to the vulnerability, when it comes to maternal and child health? Mm-hmm. So that was my concern. Thank you so much.
Thank you so much for the good question, WASH and climate. So maybe I will give back the mic to my panelists, and I can see here the series of questions. First of all, we will start financing. We have got a very good reflection from on ground. It's medical officer, DMO, yes, and has brought a very experience during CCHP planning, how difficult it is, and yet WASH is important. Can you tell us a little bit about that?
Okay, thank you very much. I really agree with the issue of looking on how we are going to prioritize financing for sanitation by itself, for healthcare facilities. And it is true. For example, the program which actually we are implementing, Sustainable Rural Water Supply and Sanitation, which have an envelope of $650 million USD, only 24% of that funds is directly allocated for sanitation and hygiene, which means it's going to address the challenges of sanitation in schools, community, and the healthcare facilities. So you can see from top, there are some issues to look on how we are going to prioritize these issues. And I really agree that for the issue of financing, of course, this cannot be done only by government, has to be done by all of the people. And in terms of investment, there are two costs maybe for my perspective, that investment cost for WASH in healthcare facilities, and there is operation cost for WASH in healthcare facilities. For operation cost, that can be actually done, need prioritization and the shifting minds of health management teams. But for investment cost, that's true. For example, we want to construct an incinerator for healthcare waste management. It goes 18 to 21 million Tanzanian shillings. And the dispensary, the total budget for all intervention health commodities up from all other sources, just around 7 million to 10 million. So can you stop doing other activities so as you can go to construct incinerator and you borrow certain amount of money to construct incinerator for that year, you close the facility, then that is not possible. So that's why we want everyone to be in this. But this does not actually remove the responsibility of the government of ensuring provision of these services. So we have been doing this through dedicated amount from the own source of the council, but the council can do it gradual. Like this year, one healthcare facility through own source, and through the government also have programs. They can have like 2, 3 within the same council. So this is how we have been working. So we work against the constrained resources, but constrained resources does not stop us from delivering, ensuring we are making increase in terms of access, in terms of what. That's a little bit I can add on this. Thank you.
Thank you very much, Seleman. We are a bit running of time, and that's a very good feedback. We are operating in a constrained resources. And I recall Anna mentioned about smart investment. That's why we are talking about costed roadmap. Is it something that, Anna, you would want to emphasize on that?
Yes, thank you very much, Sulemani, and thank you for a very good question from the ground. I really appreciate that question, Doctor. Just to add one point on the good points that Suleiman has said, is really into how we try and break the walls among us. When we talk about health system strengthening, how do we take WASH as part of it? Because the investment that we are putting in medicine, the investment that we are putting into actually curative, that can go into preventive, and one of it is WASH systems. That is the place where, as health and WASH practitioners, we need to break the walls and come into the room together. The financing might not be enough, but the financing is there. It's how we look at it in terms of investing in one arm and save the other arm. Imagine a business where you put $1 and you get a return of 9. It's only on the WASH. So I think the financing that we are prioritizing into curative, we can start taking part of it. Good evidences are there that when you invest into WASH, then there is good outcomes in terms of the other part of it. So let's talk and break the walls.
Thank you very much, Anna. I know there are some other questions on community engagement, but I'll skip that. At least we addressed the financing. I want Dr. Happiness to talk about WASH and climate change.
Thank you, and thank you, Doctor, for the question. I won't respond to it in total. I know we don't have the luxury of time, but in WASH there is a saying that we say climate change is water change, and there is no way that you can observe climate change without change and impacts in the availability of water, and then all of which impacts the health. So because of time, at the national level right now, we're looking at how to do the national climate risk and vulnerability assessment. We don't have one at the moment, and it is something that is underway. Maybe we can discuss more and we can highlight more on how we want to do that. And we hope by doing that we shall be able as a nation to look on how are we really integrating the issues of climate change, water and health. So Tina, I just wanted to add on that. I'll catch up with Dr. Antoine. We don't have time.
Okay, thank you very much. We have 4 minutes. I would like to just invite one, but not a question, because we probably will not have. Can you share a solution? I would like to call my mother there.
Thank you very much.
Thank you.
I'm Dr. Kandi, DMO Bagamoyo.
Okay.
Yep. Just advice because of this climate change, and we've seen few days after we have got this WASH program, that even DAWASA now, the pipes, I think there's some problem in the pipes, so there's no water coming to our facilities. So the advice is, can we please maybe think of drilling water instead of using this DAWASA or WASA water, because it's not sustainable. For sustainability, we need to drill water so that we can get every time, every day, water will be there. For some places then, like Shinyanga, maybe it's too dry. Even now, the places are too dry. So you can see people are using this ponds water. If you use this ponds water, how come you can get water in the facility? It's very difficult. Let's drill water, because it's not too expensive. Sometimes it's very cheap. And the places where water table is too high, like Bagamoyo and others, you just drill 1 million, you get water.
Thank you so much. Thank you so much. So I am wrapping up, recapping from all my panelists and discussions around. We all agree that WASH is non-negotiable enabler of RMNCAH from all the presentation that we got today. We all agree that? Yes. And another thing that has been mentioned is data. Ensure smart decisions and targeting. We heard from Tamisemi here, and that aligns with the theme of Tanzania Health Summit as well. It's coming very well from this discussion. Financing is very, very important, but it has to be together, like working together, because we are all targeting the similar bucket of financing that's being released through the structure. But how can we work together, partners and government? How can we have targeted investment? How can we think about smart investment, having a costed roadmap, doing it gradually to meet the gap that is existing, to cover the gap that is existing. But also integrations and coordination has come out strongly from the discussions. Again, WASH and climate. There are climate adaptation measures, including rainwater harvesting systems and many others. We know that the country is ongoing at putting the climate-related plans in place, and these are the things required also to be ensured that not only having it in plans and policy, but in practice, how are we making sure that being mainstreamed through the budgeting and planning to realize it on our implementation. So this is what I have grabbed from what we discussed. So what we need is just to take this lesson forward into policy, programming, and financing decisions, all which we are talking here is about no woman, child, or adolescents receive care in facilities without safe wash. Are we agree that? So I will give just final, like just 2 words from my panelists before they step down to their seats. Round of 2 words that you could say around discussed it today. Sorry, it's just kama vile nimewastukiza. Okay, well, please welcome.
Okay, thank you, Tina. For me, I think the key message to reduce maternal mortality and newborn, which currently we still see newborn death is still high, is really addressing the issue of WASH initiative, well integrated into the RMNCAH services. Thank you.
And thank you. And for me, it will be on integration. We cannot attain health communities and well-being without ensuring effective integration of our interventions from the healthcare facilities to the community level. Thank you.
Okay, thank you. From my side is my message is that we cannot reach universal health coverage without ensuring that there is reliable access to wash, water, sanitation, and hygiene. And by doing that, we'll be making prevention of infection, as well as preventive or reducing morbidity and mortality, which are resulting from poor wash. So let us invest in that one, and this investment has to be in a collaborative way. It's the work of everyone. Thank you.
Thank you very much. Mine is to request all partners, government, let's collaborate. Let's break the walls between us. Investing in WASH is really affordable. It can save life, and it has a ripple effect in the economy, into the health and well-being of people that we are saving. Thank you very much.
Thank you very much. Before you go back to your seats, ningeomba tafadhali tupate picha ya pamoja. Asanteni sana. Jamani, session inayofuata ni ya partner wetu wa AMREF, kwa hiyo tafadhali tunawaomba muendelee kuwepo kwa ajili ya kujoin session inayofuata ya AMREF. Okay. Okay. Picha ya pamoja, lakini pia Dr. Robinson atatoa trophy kwa ajili ya Okay, Dr. Robinson would like to hand over the trophy to the country director of WaterAid Tanzania for the participation in this this year Tanzania Health Summit. Country Director WaterAid Tanzania, please stay back for a minute. Dr. Robinson wants to hand over the trophy.